All right, good morning, folks. Thank you for joining us today for Coffee with Community Services, Alta California Regional Center's weekly service provider meeting. My name is John Decker, the Director of Community Services at Alta. Thank you for joining us today. We've got 66 folks logged in so far. As per usual, we are going to go through our agenda and we'll get into introductions of staff. We'll do staff first. We've got our specialized services and supports manager, Jordan Elleron. Good morning. We've got Alejandra. We've got Virginia. We have Michael Mercado, our deaf and hard of hearing specialist. We have our lead, Jason, on. We have Christine on from community services. From client services, we have Carol Wilhelm from our supported living and deaf services unit. From community services, we've got Sammy Lynn and Damien. Good morning. We've also got Allison, who you guys got to meet. Was that last week or a couple weeks ago in Helen's unit? And I got to meet in person in the office. And Megan from community services as well. We have a special guest speaker, Dr. Lori Aldridge, who will do more of introductions for her a little bit later. But I just got to make sure everyone knows that we see her here bright and early. Actually, it's a little bit later if you're on the East Coast, like Dr. Eldridge is. Additionally, from client services, we've got Veronica from our Woodland office manager. Thank you. And then we've got for community services, my assistant Zach is on, Ethan is on, Denise is on, Beverly is on. Our housing specialist, Rhonda, is on. We've got Jaslyn and Brandy from community services. We've got Mason and Shauna from Community Services as well. We've got our manager Helen is on. Our director of client services, aka training scheduler, Michelle Johnson, is on as well. There she is. From client services, we have Cindy Lay. Good morning, Cindy, our client services manager and community services alumni. And we've got client advocate Reva on and Isabella and Damien, as I said, from community services as well. So good morning, guys. For our agenda today, we are going to do our sign of the week and Deaf Culture 101. We are going to get a special, a little bit longer presentation from Dr. Eldridge, and looking forward to that a lot. And we're going to do a rate reform update. We've got updates on new service codes with the excessive mileage calculator. So we're going to talk about that and how we're going to get you guys set up to be able to bill for your excessive mileage. We are going to we have a spotlight with Roslyn Care, and you're going to hear from Courtney. We're going to do an update on the quality incentive program and some of the webinars that have been going on. Jordan's got an update on the CRDP RFPs. We have, and then just a little bit, I was at a conference, a housing symposium in San Diego this week. And so wanted to share some of the things that I learned down there as well. So I'm going to start by spotlighting Michael Mercado, Alta's deaf and hard of hearing specialist. And take it away, Michael.
Hello, just a moment here. I want to make sure I can see everyone's faces. Great. Good morning. Good morning. Today's sign, well, we'll have three words we'll go over. The first one is monster. The second word is bloody. And that third and final word is scream. And they're all Halloween themed signs, so that's pretty exciting. So first we'll start with monster, that first word. So you'll have open hand shapes, kind of curl those fingers forward, kind of like a monster would be attacking you, and then it's two times to the front. Monster. Monster. Yeah, that's an easy one. Monster. For that second sign, it's bloody. You'll use your weak hand, so the hand you don't write with, the other hand. And it is shaped like this, palm facing towards you. Your dominant hand, the hand you do write with, will come in front and fingers wiggle down towards the floor, down towards the floor. For bloody, you can imagine blood is kind of trickling down from your hand in that way. That's bloody. For our third and final sign, it's scream. So open hands away from your body, curl those fingers in, and then come towards your mouth and then pull away, up and away, like you're yelling. Scream. Okay, ready? Let's go over those again. Monster is our first one. Bloody for number two. And scream for number three. Good job, everyone. And I will share a link to a YouTube video. There it is in the chat. And then you can watch that video, and it's a little bit of a Halloween costume, kind of a funny video there. Please also, if you want more Halloween signs, next week will be the final weeks for you to get in your list of words. So I'll add my email address as well. You can email me any words you might want us to cover, that are Halloween themed. So now we'll move on to deaf culture. And today we're going to talk about captions on your smart TV. So for captions, most of the time we've seen them. We've seen them on our TV screens. Sometimes we see them in movies. They'll have them along the bottom, in a bar, the different words that go across. If you maybe you're not familiar with captions, we do have a new feature that offers captions where you can tweak them a little bit, and it's very cool. Those captions are for the deaf and hard of hearing. It is such a benefit for everyone else as well, though. So it's not just for our community. So it's nice to be able to know about those captions and how to access them. You'll see the word closed in front of captions. I mean, you can turn on the captions and you can turn them off. You can adjust that. It's often abbreviated CC. You can turn that off and on. So the Smart TV feature has the ability to change the size of the text on screen for your captions. You can also alter the color, so you can make it more visual. You can make them white. White and yellow are the traditional colors we typically have seen up until this point, but now you can make them blue or an array of different colors. So we have lots of options now. You can adjust the style of font for the captions as well. So sometimes you might want to see them in a more thick type font. Some people prefer thinner letters. So whatever's easiest to be read, you can adjust to. You can add a black background behind the words or a different color. It can be a dark color that you can have that contrast with. The captions move across more smoothly now as they go. And you can also adjust where you want to place them on the screen. They're usually on the bottom, but you can put them up at the top of the screen as well, wherever is easiest to see. And I'd like to talk to you about why those things are important. Of course, accessibility, more accessibility for the deaf and hard of hearing community. That visual access is easier for them to enjoy what's on TV or on the screen. The larger font is better for those who need them to just be a little bit bigger. This would attribute to our deaf-blind community, so we can make the captions just larger in size, more visible. Choosing the color of the words is great to make sure that people can see. Sometimes with the movie background, it can be difficult to see that. And we'll typically use white words. The words are white in color for the captions. And then the movie comes up and it's it's maybe the sky is on the screen. It's blue sky. And so it's hard to find the white lettering in that blue sky. So you're kind of missing what's going on there. So it's nice to be able to adjust the color to be more easily read. Also, the contrast has been improved. Also, a great benefit for our deafblind community, our deafblind users, so just more visibility. So the smart TV today has really excelled in technology and made some improvements so we can adjust those closed captions. It's still, a few things on our wish list for a few more improvements. For example, we'd like to see them be able to follow who is talking and maybe differentiate that by color. So I will be able to easily identify who's speaking and when another person starts speaking, and they can keep those colors consistent by speaker, maybe even adding their name. Um, and if there's a crowd of people on screen and I'm reading the captions, it can sometimes be confusing to tell which person on screen is actually doing the talking. Also for music, when someone is singing, in the past, in the old days, back when, in the 90s when I was a kid, I would always watch the captions and it would show music notes. The, ball with the shape that, that indicates that music is playing. music notes. Now they don't have that anymore. They've taken that away. I have no idea if is that person talking or are they singing. So that little piece of context is missing. So if we could add that, and then the sounds in the background, like laughter, or maybe it's windy, or it's more noisy than usual. That if like in a scary movie, I'm sitting here, and they don't tell me anything. It's kind of just zooming in, but I don't know what's happening. But people can often hear the spooky music in the background, so that is missed. So if we could add that to the closed captions, the background sound, that would be more intriguing for our viewers to know what's happening on screen. So even though I can't hear, I still enjoy being able to enjoy sound. And I can understand the context of the movie or the TV show that much better. The captions offer people a better understanding of what the movie is about and what the message is, and we can feel a better connection and more accessibility for everyone. Thank you for your time.
Excellent. Thank you so much, Michael. Appreciate it as always. And I will echo Mehdi's comments that you do a lot of serious information that we always appreciate through our Deaf Culture 101, things that are so impactful to individuals that we all need to know because these same individuals are the ones that we support through our services. But you make things fun too. And so I just want to acknowledge that. And I appreciate how you make things fun when we do this. And so you sit right outside of my office, and so we're going to practice Monster next week when I walk by.
Okay, great.
Okay.
Thank you.
All right. I'm going to throw it over to Dr. Eldridge now. And I want to acknowledge Virginia Gabby on our staff who has been working with Dr. Eldridge for a while now, getting our community resource development plan project off the ground. And so the slideshow looks good. Dr. Eldridge, you're welcome to introduce yourself and take it away. But again, I just want to acknowledge and thank Virginia for all the hard work that goes on behind the scenes so that we can bring these cool opportunities to you folks. Go ahead,
Yeah,
Lori.
I'm so grateful for Virginia's support and your support as well, John, for this project. And I'm extremely grateful to be here today. I wanted to briefly introduce myself. I think that that's really important whenever a new person is coming along, and what I'm doing at Alta California Regional Center. I mean, not too many years ago, I was actually sitting in your seats as a vendor. And so it's absolutely amazing to be here today and to really kind of come full circle. I knew from a young age that I would be working with people with disabilities. My cousin Amy, who is in this picture, and I grew up together in rural Northern California in Trinity County. And I remember at a young age, very young age, probably about the same age that I am in this picture and on this slide, of playing with my cousin at a rock quarry and teenage boys beginning to throw rocks at us because of Amy's disability. I remember feeling really agitated and angry, and so angry that as this little tiny 7, 8 year old girl, I started picking up these rocks and throwing them right back at these teenage boys. And that moment has shaped my work and my life. And so a lot of the work I do, it's special to me. It is because you know, the people that I am advocating for are important to me as well. And so when I was attending Sacramento State, I worked at Easter Seals. I was a respite provider. I was also working in a day program at that point. I was really curious about all the systems within the regional center and the developmental disability service sector. And so I had the opportunity to become an administrator of a care home. And so I was able to do that. In that role, I learned to drive a bus and do tie downs and do all kinds of amazing things. And it was a lot of work. I then was able to eventually fast forward, finish school. I moved to Los Angeles and I worked in a psychiatric hospital in Southern California. And I worked there for about 5 years. And I really began to develop a love for mental health and specifically substance use disorder because I worked on a addictions unit. During that time, I had a professor that was at Sac State that contacted me. Her name's Heather Kinsey, and she reached out to me about an opportunity to open a new day program. And this was a program for people with intellectual and developmental disabilities with co-occurring mental health diagnosis, and also substance use disorder. Now, right off the beginning, I knew that this sounded like it might be a challenge, but I was up for it and I was really excited. And I jumped at this opportunity and moved back up north to Sacramento. And over that next year, I worked with Dan Kilmer and others to prepare the Milieu Center. And in November of 2007, we opened the doors of the Milieu Center. And the center grew and it's changed over those few years. But one thing that I kept running into over and over again was that I couldn't find resources for my staff and for the people that I was responsible for. Like, I was their boss, so I wanted to be able to provide resources for them for substance use disorder and intellectual and developmental disabilities. And I searched high and low. I was looking everywhere. John Decker was a great resource, and he was awarded a grant around this time from the Developmental and Department of Developmental Services through the Mental Health Services Act. And his team began to do trainings throughout the Alta California catchment area on substance use disorder with mental health providers, with substance use providers in the community, and then also vendors like myself. And what I really kept coming up to again is I still don't have the resources. And I just assumed that I just didn't know where to look. Now, during my nearly 20 years of experience of working in mental health and then working in the IDD service sector, I realized that evidence-based practices became really important. When I was in college, I didn't even have a home computer. So things had changed, right? So I said, you know what? It's time for me to go back to school. I don't know where to look. I think that I just don't know what I'm doing. So I picked up my family. I left the Milieu Center and got my PhD. Now, my passion for substance use disorder and intellectual and developmental disability has never left me. And that's what I focused on while I was doing my PhD. And what I found is that it really wasn't me. It was that these materials and curriculums didn't exist. They were almost nearly non-existent. And so through my training, I really focused on how to and what is needed. And so I was trained as a public health implementation scientist. And so that's a very fancy way of saying that I take research and I put it into the real world. I put it into organizations and I focus on organizational training and curriculum and development of improved health outcomes for underserved populations, really looking at people with disabilities and also people in rural communities, because I am from a rural community. So if you fall within a rural community and you have a disability, that's where I really want to be. So both of those are really dear and near to my heart. And so as I talk today, I just want to share that I am so grateful for my experiences as a respite provider, as a day program worker, as a care home administrator, and a day treatment program director. These experiences have laid the foundation for all of my work. And they've shaped who I am and what I do and how I approach my work. And so as we move forward in the next couple slides, and I share with you about what we're doing, I'm really excited about this work, and I hope that you will join me and be a part of it as well. It's innovative, and I'm really excited that the Regional Center again is just like they were a few years back when they had that grant on substance use disorder. They're taking a really big step forward on the national map to be able to make change and to lead the way. And so I'm really excited to be here. And I just want to thank the Alta, and then also, John, thank you for letting me be here. And I also want to say that when I did my dissertation, And I'm going to talk a little bit about that because that shapes what we're doing here. The most important line that I wrote in my dedication was my dedication, and that was to my cousin Amy. And this is what it says, and I'm going to read it. Dedicated to my cousin Amy, who has shown me that ability means more than disability. And so all of my work is focused on those principles. And I'm just really grateful to be here. It's really kind of unbelievable, and I'm so grateful. Thank you. All right, so I'm going to dive in a little bit and just share a little bit of information about substance use and intellectual and developmental disability, just to kind of get us all on the same page. So there has been an increased access related to substance use treatment for individuals with substance use disorder overall for everyone, except people with intellectual and developmental disabilities. They're still being overlooked, unfortunately. And substance use is most commonly found within the IDD population with people that have mild or maybe borderline intellectual functioning. And some research suggests that being male, living independently, having a co-occurring mental health diagnosis, and having limited connections will increase your risk of developing a substance use disorder. So I think if you think about the people that you serve, if you know you're kind of checking those check boxes, male, living independently, has a co-occurring developmental disabilities, having someone who is engaging in substance use, even if it's not in an addiction way, but maybe just experimenting or just every once in a while, there is a high risk at that point. So overall, studies have suggested that around 5% of people with intellectual developmental disability has a substance use disorder. But I'm going to point out that a lot of the epidemiological data, which is like who has it, where does it come from, all those things, a lot of that data is coming from outside of the United States. And so the data that we have in the United States is outdated and very limited. And so that's where I step in, and that's really where I'm trying to move forward and push and get more information and also change practice in how we engage. So I wanted to share, I mentioned just the previous slide about my dissertation, and some of the work that I did was looking at substance use, healthcare and healthcare practices for people with intellectual and developmental disabilities. And so recently, a study was published by myself and a group of us that was a system capacity assessment. And that system capacity assessment was all of the regional centers. So it was the regional centers of California. And what we did is, and what I did is I conducted interviews and surveys amongst all the regional centers to understand what substance use disorder treatment look like. What did substance use treatment look like in California within the regional centers? So what we found was that people with intellectual and developmental disabilities who do have a substance use disorder often face substantive disparities across the healthcare continuum, not just related to substance use treatment, but also just obtaining medical care, obtaining mental health, and all those other practices within healthcare. And I think that if we were sitting across the table right now, you would agree that that is not unique to someone who has a substance use disorder treatment, but nonetheless, substance use disorder treatment falls within there as well. Now, what we found was that there are very few number of vendored substance use disorder treatment programs within this entire California Regional System Center structure. And most of the programs, even if they were vendored, they did not specialize in IDD. And so what's unique about that is that I found was unique was that these are vendored programs, yet they didn't specialize in IDD despite being vendored for that purpose, right? And so that was concerning. What we found often, and what I like to say, is that they were able to get them in the door, but anything beyond the door was really falling apart and the clients were falling through the cracks. And I did interviews with service coordinators throughout the state, and I heard the same thing over and over again about that. And then also talking with the substance use disorder providers, and they said, we're at a loss too. And so the experience was shared, meaning we're not really sure what to do on both sides of the table. Both the client and the provider's stigma strained their care, and providers lacked that cross training. So when I talked to service coordinators within the regional center system, often they said, we don't really know much about substance use disorder. We're not really sure what we're supposed to do or how we're supposed to access that. We're not sure about that information. And then substance use disorder providers, even the ones that were vendored to provide service, were saying, well, we don't really know how to work with people with intellectual and developmental disabilities. We're not sure how to do this. And so that lack of cross training really created an environment in which our clients would then again just fall through the cracks and not get the treatment that was needed. What we found too is there's significant gaps in resources, adaptations, and research in general to support this population. And so what we're doing here today is really to start to address some of those gaps and to fill some of those holes that exist, because it's time for us to start connecting and talking and kind of reaching outside of our silos and stepping outside of that to be able to make some change. So how are we going to do that? So one of the things that we did as I was developing this is I interviewed, again, service coordinators. You can probably see a theme here. My work, I always work with the people that I'm working with because you guys know best, right? I used to be a vendor, so it was very important to me that I speak to people who are engaging in this work, that are boots on the ground. And as I talked to people, I realized, and a lot of my practice experience kind of came up again, which was, this service industry has a high turnover rate. I could come into the regional center, I could come into your care home or into your day program or wherever you're at, and I could come and do a training. I could do 3-day training. I could do a 1-hour training. But the reality is the only people that got that information were the people in that room at that moment, at that time. And so I started thinking about ways that we can make this sustainable. When I was a care home administrator and a day program director, that was really important to me. I wanted to make sure that whatever I did was sustainable and that I could continue to do over and over again. So that's where the train the trainer model came in. And I'm going to talk a little bit about the benefits of that and what the goal of this model is. But what I want to share is just kind of the outline of how we use the train the trainer model. So this framework is where we bring one individual, often like a lead, an owner, a director, into a training, which will be held November 10th. So write that down, November 10th. That's when we're having it. And Virginia is going to drop her email into the chat at sometime here. And you guys can register for that training. But that leader comes in. I provide a trainer. I provide the training. And then what happens is you are now the instructor. And you go out and you train your team. Now, what I know from my experience is that that's really powerful, because I could take information. For example, I had to do SIR training every year when I was a director. And then what I would do is I would come back and train my DSPs and my floor staff and even my nurse and everybody around me, right? My psychologist, everybody. This is how you do a special incident report. That's how I did it, because I know how to teach my people. I know my people. So that's what this is about. You know your people. You know what best mechanism, the best time, and how to engage with them. So what we do during this time is we create the opportunity for you to provide that education. And now every one of these, in this train the trainer model, we have different, what we call micro trainings. So we talk about the neurobiology of substance use. We talk about substance use, like what is substance use? What are substances? And give that kind of core information. We dive a little bit deeper too. We begin to get into motivational interviewing. And what is motivational interviewing? Why is it so important? And I'm going to give you a big hint here. Motivational interviewing is not just about substance use disorder. Motivational interviewing has been shown to work with people with intellectual and developmental disabilities in food, exercise, work, hygiene, a lot of different ways. I can give you all kinds of literature for it. So just that alone is a huge takeaway to be able to teach your staff how to do motivational interviewing. Huge. And then we'll talk about SBIRT, which is a way to screen for substance use, do a brief intervention, and referral for treatment. We'll also, one of the other trainings is about compassion fatigue. I know that when I was a director, that was real. It's still real when I'm working in substance use, when I'm working in the IDD field. Compassion fatigue and burnout is real. And we want to make sure that we're addressing that, we're aware of that, and that we are building our employees up so that they'll stay, right? And the goal is that as we do the train the trainer, we have this multiplying effect. So we kind of keep going bigger and bigger and bigger, and we make this web of information. So let me talk a little bit about this, some of the goals here. One, we want, with the train the trainer, we want to build that internal capacity. This is about you building the capacity to change your culture and to change your environment, and to not only do maybe substance, the micro trainings that I'll share in my training, but other trainings as well. You know what needs to happen. Maybe it's SIR, maybe it's nutrition, maybe it's transferring in a wheelchair. But you've now built the internal capacity with the train the trainer to make this happen, right? We want to ensure consistency in delivering of the messages. So the materials that I've developed for this program, it has all the facilitator notes. It has all the engagement activities, and then you get to take it back and you get to provide it to your staff. But we have a consistent message. What's amazing about that is that we've already had the service coordinator message. They're going to be distributing and doing the train model with their service coordinators. So the managers are going to be taking it to their service coordinators. Now you take it and you give it to your staff. Now, all of a sudden, you guys are speaking the same language. You're on the same page. You have an understanding. And that's really powerful. What's nice is, again, you can scale this training across lots of different teams. If you have multiple homes, you can train, and then those people can train, and vice versa, or multiple day programs. It provides an opportunity for you to build leadership amongst your staff. If you have people that are strong and you want to build them up, this is a great way to do that. It allows them to be a leader, it allows them to engage and kind of take those roles. And when people feel that they have ownership and that they are responsible for something, they're likely to stay at their employer. And that's so important. I mean, I know for me, that was really important. And then also it strengthens that workplace culture. You're meeting, you're learning together, you have shared information, shared experiences, and then you also have shared standards, because now you're doing these trainings and you have this understanding of, like, this is how we're going to do it from now on. And that's extremely powerful. Now, I'm going to just talk real quickly about some benefits, and we've been talking about them as we've gone through. And then I want to make sure that we give you guys some time for questions and to be able to ask questions to me if you have any. So what are these benefits of the train the trainer? One, it's cost saving on multiple different levels. First of all, if you were to bring a trainer in every single time you had a new employee to give them information, that's really costly. I know that whenever I had an employee leave, whether it was when I was the care home administrator or a day program director, that cost me money. That meant that somebody left that I had already trained, and then I needed to bring somebody on and I needed to train them. So when you have this, and then if I have that training and I'm bringing people in to train, I have to pay them to come in and train. So this brings it in-house, right? So you have that cost saving. Additionally, because you're giving education, because you're building them up and you're building their skill set and you're kind of adding tools to their toolbox, they're going to feel invested. They're like, I have the tools to do my job. I know how to do my job effectively. And that's really important. When someone doesn't feel that they have the tools to do their job, or that they are not able to do their job because of lack of knowledge. Maybe they have the passion and the desire, but they just don't have the skills. They're probably not going to stay very long, because nobody wants to stay in a place where you feel like you aren't effective, So this really builds up that piece. And like I said, it saves lots of dollars. Consistency. You know your staff the best. You know your employees the best. You can be consistent. You know when you have staff meetings. You know when you can do this. You don't have to reschedule. You can just build it into what you already have. And that's so important. I know that when I was doing training, we did a meeting every single Friday in the day program. And so I knew that if I got some new information, I could put it in my Friday meeting, and that I could consistently do that over and over again. That was really important to me. My staff, it was important to them because they knew what to expect. They knew they were going to get a little training piece, 15 to 20 minutes. Relevance. Now, you're going to, all these materials, right, are provided to you. You're going to have this large electronic workbook after you leave the training. You're going to have all these materials. You'll have me for about 6 months afterwards, where we can connect and work through materials and talk and do that kind of stuff. But you know your staff. You know what language they prefer to speak. You know how they ask questions. You know their body language, like if they're not understanding or if they are understanding. And so you can make the examples. I provide lots of case studies, but you may have examples and case studies that you want to work through at your house, at your program, in your work environment. And so you can make it and shape it so it's relevant to your people. And that's really important. It's not like I'm trying to fit a square peg into a round hole type of thing, right? You get to shape it. It's clay. You have the materials, and now we can shape it. And I can work with you to do that over the next few months after the training. This, as I mentioned previously, that leadership growth is amazing. You build up those people, you see those strengths, and you give them those opportunities to take ownership over things. And I think one of the keys is that the train the trainer model, it's sustainable. It's something that you can do over and over again. Repetition is important for everyone. So if you want to do the neurobiology or SBIRT training 5 times during the year, great, do it. But it's sustainable. You don't have to bring an outside person to do it. You don't have to bring in and schedule somebody else and then pay them all this money and to have them come to a training. You can do that. And so that sustainability and being able to keep all of your employees on the same level with the same knowledge is so important. And so, because then you have consistency of care, and consistency of knowledge then helps to bring in that ability to have sustained employees, sustained care for the clients, which is what we want. And that's the most important, right? Is that we are providing consistent, sustainable care to our clients. When we lose an employee, that decreases, and it creates risk. And so being able to have sustainable training is really, really important so that we can make sure that that happens. I want to give you guys some time for questions. And so I'm going to close down my slides so that I can see all of you guys. And
Okay,
so I'll stop.
Lori, let me just do my little plug here. I want to make sure I'm
Yes,
clear.
please,
For
please.
for your capacity here for your upcoming training opportunities for service providers, what's the
Right.
number, Virginia and Lori?
The number is 20, and
All
we
right.
have about six spots left.
Okay.
6 spots left. All right. So with that, there's a couple things. One, make sure we've got Dr. I dropped one of your many greatest hits into our chat here, one of your articles
Great,
from
thank you.
Impact. And then want to make sure everyone has Dr. Eldridge's contact information so that you
Yes.
guys can reach out to her directly. Virginia's going to put her information in there as well too, because if you want just more information about what we are doing as it relates to kind of supporting in this area, that is something that we'll have you stop sharing.
Yeah.
Thank you. That's in the chat there. And then
Thank you.
I just want to say, like, this was a big, issue at our regional center, a decade ago, where we were really focusing on substance use disorder. And as Lori said, trying to increase the competencies of you service providers and recognizing these needs that we know are going on within the services that you are providing. Like we know that it is happening. And so really, this is a great support. So I want to say thank you, Lori. And Lori, I also have another special guest, our friend from the wellness manager from Westside Regional Center, Aga, is on. And so I'm going to
Hi.
share I know. So I'm going to share my screen because you referenced the MHSA grant, and I'm going to ask
Mhm.
her to actually introduce this training certification that they have put on. And she can mention briefly about hopefully the replication project that they are doing, taking some of our stuff that we worked on a long time ago and
Mhm.
really fulfilling a lot of the goals that we had. So I'll ask you to introduce what this is.
Hi all, and I'm so sorry for crashing and taking 1 minute of your time, but it seems like a perfect opportunity to also I mean, Lori, your stuff is amazing. I so wish we can do something and replicate something similarly here. So I'll connect. In the meantime, you guys check out the flyer. We've used the amazing work done by Alta under John's leadership. We used that amazing ideas and kind of, took them into now more of a techie world, right? So everything is on e-learning platforms, everything is accessible. It's a 5-module type of a course, self-paced. It's on LMS, the ARCA kind of, funded learning platform. Check it out. It's all that you need to know about substance use disorders, how to work with people. You should still take Lori's, training, but this could be in addition to, this could be like some modules might be appropriate for you and on your staff to refer to after, before. Check it all out. Yes, thank you for sharing all of this. So that's it. There's also a different component that we took on, which is to develop a peer mentoring program. And this is going strong. It's under Sober State. It's going strong. It supports, I think at this point, 25 people in recovery. They are trying to do vendorization across different regional centers. Keep an eye out. Maybe they'll reach Alta as well. They're amazing. And that's it. If you have questions, I'll put my email address, although it's on the flyer. Thank you so much.
Awesome. I really appreciate that. Any of you that do this work and you just heard Lori describe it right now, having different types of opportunities for training is really important. Having, as Lori said, like, your staff. Some people might benefit from an online training module. Some people see having a train the trainer module, training going on and setting kind of that establishment throughout your another way. Aga's talking about the utilization of peer mentors, which Jordan knows how much hard work we did with Andy when he was part of our unit to get that stuff off the ground. And so I just, all the stuff you guys hear me talk about now, as far as housing, if you would have rewound 20, 12, 13 years ago, I was talking about substance use disorder treatment and trying to really enhance our local, community-based service providers so that they understood developmental disabilities and really help support you all as service providers to increase your competencies. Our agency is really focused on housing items. And so that's one of the ways that we can really be responsive to this huge stakeholder need that we know occurs, is supporting some of these other things. And so, the things that Westside has been putting on, they just like the other stuff, it's made by a regional center and benefits the whole state of California, what the product that they create. And that's the same thing for the CRDP project that Virginia is overseeing with Lori. All of the community services directors throughout the state have known about, Lori's work. They've received, the articles and things like that, because we want to share these best practices throughout, the state, because there's not a lot of experts in this stuff. And these guys are really stepping up for our system. These two specifically, actually, here. So anyways, wanted to touch on that real quick. It is something that I am very passionate about, and we don't talk about it all the time here. So thank you guys for sitting through all this.
And I just want to add to it, I just want to acknowledge that I know that this is working with and supporting someone who has co-occurring disorders and then substance use. it can be difficult and you can feel really lonely. I often would say, I feel like I'm on an island by myself. As I've reached out across the nation, a lot of people feel that way. And so what I'm really hoping to do is just to continue to connect hands. And as John said, we don't need to gatekeep information. Like, we don't need to do that. We need to share it. It needs to be public facing. It needs to be sustainable so that it doesn't get lost in the shuffle of employees retention and like moving in and out and employees moving, because we know that that happens in this field. I know for sure. I was there. I did a lot of that. And so what we want is that it can continue to go forward and move forward, and that we're sharing that information. So I'm really excited, and I love the work that Westside's doing as well. The more we have, the better. And again, we want to talk about prevention too, because it's not just oftentimes what happens, we find our individuals that have a substance use disorder because they've been arrested. And so let's be proactive and try to catch it before it gets there. That's the goal here. And so the more people that can get engaged in this work, even if you don't have a client, get engaged with the work so that you can be a part of that prevention effort.
Excellent. We are shifting gears radically to talk about the excessive mileage calculator now, folks. Moving over to rate reform now, because I want to use everyone's time really wisely and make sure that we get this updated information in Carol Wilhelm's hands right now today, because this is important. I'm not joking. You think I'm joking, Carol? I am not joking. So what I want to display, and I just have to say that Norma is not here right now, but I like to give credit to our staff that really put a lot of work in on special little things like this. And Norma has really had to step up. Norma Vidarueta is our lead community services specialist, and she worked on some correspondence to send out to all of you service providers related to this, but we've got new updated information, which is the Department of Developmental Services has added additional service codes to the excessive mileage calculator, including service code 896, Carol, supported living services. So I know we've got probably 24 or a dozen at least SLS agencies that are logged in here today. So the new service codes that have been added, Helen, Beverly, we might have a few behavioral vendors on, I don't know, but they've added the following additional service codes to the excessive mileage calculator, and the department expressed yesterday that they may be adding more in the future based off of feedback from regional centers related to mileage challenges. They have additionally added service code 612, behavior analyst. They've added service code 616, which is behavior technician paraprofessional. So think about those individuals that are working, providing, early autism treatment services out in people's homes that may be traveling long distances. We are one of those regional centers that was noted that this could be possibly impactful for, because of our large catchment area, and that some of these service lines, it's hard to find people that are local. But supported living services has also been added on this too, because this is something that has been certainly brought up. So I want to just, we went through this, a week ago or something like that. The calculator remains the same. You choose what your service level is. So let's say I'm doing supported living services, and there's no rate variation. And I'm going to pick, Carol, how many billable hours? Let's guess. How many billable hours might someone be doing on average or so?
462.
400. Let's say someone's doing 462 billable hours in the month. And let's see here. What do we got? Where's my calculator at? Oh, do I have to choose regional center first? And then, because there's a geographic multiplier maybe. Actual miles. How many miles, let's say, can we get a guess?
For a month?
Yeah.
350.
SLS providers, you can play with this too. One of you can shout out a number if you want.
Yeah.
What'd you say, Carol?
350.
All right, let's call it 400 because this person had to drive extra far.
Okay.
Unfortunately, there's 1,617 miles that are actually built into that rate if you build for 462 hours. So therefore, you have no excess mileage costs. But let's just say during that month, for some reason, you did 2,000 miles of in that month. And here's the second part of the calculator that I want to make sure I focus on, and then we're going to switch over to our spotlight. Is that the department has changed the definition to say that this would include mileage associated with travel to and from service encounters. That was not on the previous language. It only said between appointments and taking clients out into the community. It didn't say to and from. So we asked for that clarification. I would give a shout out. Eric Champa's on here from UCP because he's the first one that let me know that the department might be changing their minds on that and it was a mistake. I spoke to the deputy director and we got some great updated language for us. So how you initiate the contract authorization is going to be really simple. The calculator, which once I close this, I think I can drop into the chat for everyone, or maybe Jordan can drop it into the chat. You just save the file on your computer and then upload it into the chat. All you do to initiate your contract auth is put your mileage in for the service. If it pops up that you're owed an excess mileage payment, you send that into us, like send us a copy of the calculator, and then we will initiate your first contract authorization. You'll send that into pos@altaregional.org. Norma wrote up beautiful instructions that I believe I'm going to try to update now that we know that we're going to be sending this out a little bit more widely. I think, Jordan, we're going to send this out to everyone because the department let us know that if there's other vendors, like I think vendors need to know that this thing exists out here outside of those service codes. And if there are other impacted vendors, I encourage you to contact your community services specialist. Let them know that you are going over the mileage that is built into your rates and that you want an opportunity to, because we have to ask DDS to add your service code if it's not one of these ones that's in here. So I think that'll be the plan, Jordan, for communication to our vendors. We will follow up with it at our PAC meeting in like 2 weeks. Eric, yeah, please.
Just a couple important notes on this one. So yeah, we were super thrilled when the department confirmed when we asked the same question if the to and from is on there. So I just want to give credit where credit's due. They've jumped in. We asked specifically, is DDS setting policies about what providers should or have to do regarding mileage reimbursement? They told us no, that they just don't want to get into how businesses operate. So you as an agency still largely get to decide what your internal mileage, like if it's not legally obligated, what kind of mileage you want to pay. But if you're going to claim this reimbursement, you're going to need to maintain your supporting documents. Right. So you
yes, we are not digging into how you guys are spending your money that are built into the rate models. I'll be honest with you. That's not part of our job to do that stuff. You're given that money and you're going to figure out how to use that. But yes, if you are claiming excessive mileage, you're going to have source documentation to show all of this and the fact that you went over. So you got to retain that documentation. We're not going to request it initially. That's not part of your request to set up your contract authorization. Eric made a very valid point that the regional center will get involved in looking at it possibly for excessive mileage.
And this does not require you, this is not a policy requirement for your company. Your company still needs to do your due diligence and decide what sort of mileage benefit policy they do not want to set all SLS mileage reimbursement policies across the state with this. So just be mindful, or ILS or respite or anything else. So just be mindful of that. That's all.
All right, folks, I would love to talk about that more. I want to get to our spotlight real quickly. And so I wonder if we could please get Rosalind here. And I apologize for the short time that we have here, but would love to give you an opportunity to share about your service.
Hello, everybody. My name is Courtney, and I am the care coordinator for Rosalind Home Care. I've been with Rosalind Home Care for about a year now, but I have many of years of experience. Serving in our healthcare community. I would like to share my screen. Give me 1 second. Can you guys see my screen?
It's great, yeah. Well, we lost it.
Oh, you lost it? Sorry.
Well, we're seeing your desktop now. We saw your presentation for just a moment there.
Okay, can you see it now?
Yeah. Looks
Okay,
great.
so sorry about that. I wasn't prepared. Alrighty. So like I said, I bring many of years of experience serving our healthcare communities. One of my favorite parts of my job is actually fitting caregivers in homes with clients. It brings me a lot of joy to make that connection with the caregiver and a family, and make sure that that family is being taken care of properly. Roslyn Home Care, we provide services in for many different families, in many different homes and situations, all over Northern California. We provide anywhere between respite care to post-op care, as well as we help support the daily living activities such as hygiene care, meal prep, medication reminders. All of our caregivers are engaging in the homes. We're not just there to fill a shift. We actually believed in building a connection with the clients. We have a whole person care approach. So we take time to find the right caregiver to put into the home to make sure that that client or family has the proper care, and that we can adapt the care plan to the actual client, making sure that their social and emotional needs are being met and they are being engaged properly and meeting goals that the family might have for their care plan. All of our caregivers are trained, as well as they have to go through a FBI and state background check, CPR, all the normal things that you know an agency would provide as a caregiver service. But what sets us apart the most is that we understand that each client is unique and so is their care. So therefore, not only do you have an engaging caregiver in the home, but we follow up and we make sure that um, each caregiver is on time. We have backup caregivers to make sure that the client is taken care of when the schedule is desired. Our care doesn't stop when the service day stops. I make sure that I am reaching out to the family at least once a week, and building that open line of communication. The more that we learn about our families and the clients, then the more that we can understand their likes, dislikes, their personality, the family's goal for their care plan. This way, then the trust is established in the beginning, and we make sure that all lines of communication is there. So therefore, the family can feel safe with leaving their loved one in the care of Roslyn Home Care. Like I said before, we make sure that we follow up with the client at least once a month, and the caregivers, to make sure that their care plans don't need to be adjusted. If they do need to be adjusted, then we work with the family as well as their healthcare team to make sure that things are happening with the client and their care plan is on point. This way, we give the family a peace of mind that their loved ones are safe and happy and well taken care of. Roslyn Home Care is honored to be a trusted care partner with Alta Regional. We want to make sure that you guys have the tools that we offer, so therefore you can better assist your families and find them dedicated caregivers to go and support them. I want to thank you guys for your time today, once again, and we are always here, just a call or an email away. I'll add my
Courtney, I was gonna say, can
information
you
in the chat.
in the chat?
Yes.
Oh, thank you so
Yes.
much. And thank you for telling us about you. And we do these spotlights to kind of get to know people a little bit too. And so I just appreciate you. Thank you for taking the time to share all of this with folks. Hopefully we can get your information in the chat so people, if they have any questions or they want to reach out to you, but appreciate you sharing with us. There's a number of other things that we dropped in the chat right now. Just going to mention them real quickly and then hope everyone has a great weekend. So in the chat, we've got information about our upcoming board meeting in November. I think we let folks know that our client services directors or ADs are going to be doing a plug that we want your attendance at that meeting between now and when we do our public meetings in November to go over the national core indicators and our performance contract. Aga dropped some additional information in there as well. There's also some, Jordan dropped the excess mileage calculator in there so that you can take a look at the new language that the department has included related to the to and from transportation. Jordan put information about the community resource development plan. I'll do more of a presentation. We've got some housing projects, but Jordan's got a specific enhanced behavioral supports home for children that she's RFPing for. We're going to do the home developer organization right now, but concurrently, we're also going to do for the service provider that's going to be running the home. And just Jordan, real quick, when are we going to looking at proposals due for that one?
Well, so we're having our public meeting on November 6th, John. So I'll put that information in the chat if people just want to save that. So we're going to introduce the project, and then our deadline for the proposals is going to be, I believe it's everyone will learn about it at our meeting, but we are looking at December. Sorry.
It'll be in the meeting.
December
The main thing is
3rd.
come to the
December
RFP
3rd.
orientation.
Yeah.
On our website, because I know you guys all follow our YouTube, I did a 1 hour long RFP or statewide RFP orientation for the expansion of the roommate matching app statewide. So you guys are welcome to, we're not RFPing for it ourselves, but we did support all the other regional centers throughout the state so that we can have an expansion of housing access services. That's on our website. And then I dropped the ARCA Capital Currents on there because there is a plug for the California Policy Center for Intellectual and Developmental Disabilities supported decision-making symposium that's next week. And so if anyone is there, I will say hi to you because I believe I'm on one of the panels. So I hope everyone else has a great weekend, and we will look forward to talking to folks next week. Take good care. Thanks for all the presenters. That was awesome.